Thank you for being here with us this morning. Welcome to the first webinar of 2026 for UC Davis Resource Center for Family Focused Practice. My name is Geraldine Bordage. I'm a specialist here with RCFFP. Well, thank you everybody for participating. We are going to go ahead and get our day started. Please feel free to continue adding that in the chat and I will go through it. Hopefully I can log back into my computer and I can go through it and look through a little bit more. But James, if you want to go ahead and get our slide deck up, that would be great. Wonderful. Okay. So again, thank you for being here this morning and welcome. If you're just joining us, this is the Strengthening FFPSA Implementation webinar for the updated guidance and the QI requirements. I'm Geraldine Bordage. I will be hosting and facilitating for today. And with us also are my colleagues, James Williams and Jasmine Montes, who will be providing support with our tech today. We are joined by our presenters, Bill Moore, and with the California Department of Social Services, and Areli Hernandez Almaraz with the Department of Healthcare Services. And they will be sharing some of the updated guidance from ACL 25-52 and BHIN 25-031 and the qualified individual requirements. Bill and Areli will introduce themselves a bit more when they begin their sections. Jasmine and James, let's go ahead and drop some of our handouts in the chat for everyone to access. And if you could go over to the next slide, please. Okay, so there's our presenters for today. And next slide. So this is our agenda for the next couple of hours. We are going to be going over some key terms, the QI referral assessment and report when a placement disruption occurs. We're going to be talking a little bit about updating the CANs, privacy and confidentiality for the QI assessment activities and the QI assessment report, updated QI referral and QI assessment report templates. We're also going to be looking at or giving some information on the tribally designated QI certification process, and the ongoing QI monitoring. We are holding questions until the end. We did have some time carved out for that, but you are welcome to add questions in the chat and we'll try our best to answer them, okay? Next slide, please, James. And these are going to be some key terms that we will be using during the presentation. The qualified individual, the QI certification, QI referral, QI assessment report, county placing agency caseworker, tribal placing agency, placement disruption, placement setting, and youth. So we do have handouts for that. So please refer to your key terms handout if you need some additional clarification on what some of those terminologies mean. And with that, I will hand it over to Areli for some introduction and to get us started on our agenda for today. Areli.
Thank you, Geraldine, and thank you, everyone, and good morning and Happy New Year. I'm glad that you guys are here with us today. My name is Areli Hernandez, and I am an analyst with the FFPSA units with Department of Healthcare Services. So thank you all for being here today. And we do want to go ahead and get started with the slide deck. Just a quick background on the QI referral. And assessment and report. So quick background is we expanded the guidance in the ACL/BHIN to include more information about the assessment process when there are multiple placement disruptions in a short period of time. This new guidance is meant to help QIs do an update to a recently completed QI assessment when a completed new full comprehensive assessment is not necessary. We will touch base on some examples of placement disruption in a later time on the slide deck. Okay. I am so sorry, James. I think I'm going over. Oh, there it is. I apologize. Okay, so on QI referral guidance. So just a quick reminder, since this is piggybacking from a previous BHIN, which is an ACL 21113 and BHIN 21060. A QI referral is required for each SERTP or CTF placement. This includes situations when a youth experiences a placement disruption and subsequent SERTP or CTF placement is being considered by the Child and Family Team, also known as the CFT. The requirements for a QI referral are found in ACL 21113, BHIN 21060. The Federal Department of Health and Human Services Administration for Children and Families, ACF guidance, clarifies that the language for each placement includes events such as youth's change of address that has an impact on their care and treatment. However, a change in facility license number or address does not automatically require an additional QI referral. In these circumstances, an additional QI referral is only required if the youth's condition has changed because of the changed license number or address. If there is a facility license or address change, a new QI assessment is required by federal and state law for each placement into an SERTP. The QI referral process is focused on the youth's clinical or behavioral needs, not on the SRTP's administrative needs. So as Geraldine mentioned in the introduction to refer to the handouts, we do have a list of the key terms in the handouts with the definitions, and we're going to be speaking to the placement disruption. So if you are unable to access the handouts, the definition for placement disruption is as follows. A transfer from an existing placement setting, absence from the placement setting for over 14 days, or other experiences related to the youth's placement setting that have the potential to negatively impact the youth, including trauma, safety, and interpersonal factors. So in this scenario, we do have a scenario shown on your screen, and also it is a frequently asked question, is if the SRTP has several locations and a child is moved from one SRTP location to another location within the same company, but from one county to another, would this be considered a placement disruption? If so, would an additional QI referral be required? And in this scenario, yes, this is considered a placement disruption and will require a QI assessment and a 45-day court hearing. If an agency has more than one SERTP and the team decides the youth should move to another SERTP within that agency, a new QI referral is required. In that QI referral, the referral must include an explanation for why the move is better for the youth. And a reminder, each SRTP has its own license and approved program plan, even if programs are similar. And last, the team must show why the new SRTP is a better fit for the youth's needs. Okay, and another scenario that we do come across or a frequently asked question is, what constitutes a youth's change condition because of the change of license number or address? So because the spirit of the guidance is that the team should consider all changes to a youth's SRTP placements and how they could affect the individual youth. Maybe the SRTP moves to a location that is not that far from the current SRTP, but could place the youth into a different school district. And even if the youth stays at the same school, it changes their transportation, which precludes them from participating in an after-school activity that they enjoy and has been important in boosting confidence and creating a friend group. And last, we do have another scenario, which if any of the following would require new QI referral if a youth is changing facility license number or address for one of the following behaviors that were known present at the time youth was placed in an SRTP that are being moved from. So some of these examples could be youth ran from placements, youth assaulted a resident, youth assaulted an adult, for example, a staff member, or youth engaged in a substance use, So again, we do need to consider the spirit of the guidance. Is the team looking at the current set of circumstances of this individual youth and perhaps the other youth in the SRTP? There could be a number of reasons why a youth engaged in any of the examples listed above. Maybe the youth ran from placement to say goodbye to a family member that was not listed in their approved visitation list, and this is not an ongoing behavior. The team will need to determine why the youth did whatever they did and whether or not changes could be made in order to maintain the youth in the current SDRTP. Okay, so now that we talked a little bit about placement disruption and the definition for placement disruption, these are the examples that they are also listed in the ACL. And the examples include facility changes causing youth distress, and environments that negatively impacts the youth or causes incompatibility with between youth within the facility. Apologies. This could include safety, trauma, interpersonal factors, an SRTP or CTF program change where the new SRTP CTF is not a good fit with the youth's identified needs. The youth is away from the placement for more than 14 days and returns within the first 30 days of placement. And the youth is away from the placement for less than 14 days and is then placed in a different SRTP or CTF within the first 30 days of previous placements, or the youth is relocated to another SRTP or CTF. So again, these examples are also mentioned in this new ACL/BHIN. Okay, so now handling multiple QI referrals. When a QI assessment is already in progress, a subsequent QI referral should be assigned to the same QI, ensuring the youth is not overassessed and there's no duplication in recommended services. Please note that when this situation happens, the QI is required to complete the first assessment in the required timeline, which is 30 days from the referral or placement, and complete the second one in the required timeline 30 days from the new QI referral or new placement. QI responsibilities upon receipt of the QI referral. So as required under WIC section 4096G and ACL 21113, BHIN 21060, upon receipt of the QI referral, the QI shall confer with the CFT, and in the case of an Indian child, they must consult with the tribe and include a determination of the social and cultural standards of the tribe. They must assess the youth's strengths and needs and identify the youth's specific short and long-term behavioral health goals treatment needs. The QI shall also review the medical record, including any prior QI assessments, progress notes, and CFT notes, and the youth's placements and service history, and make a clinical decision. Okay, so for the clinical decision, there are two options. Excuse me. Option A, that this includes if the QI, option A includes if the QI's review of the medical record indicates that a comprehensive assessment is clinically indicated, then the QI will perform the assessment and update the QI assessment reports, including a level of care determination, recommended services, or both short and long-term goals. Or option B, which be the baby blue dots, and that is if the QI's review of the medical record indicates to the QI that the medical record review is sufficient to complete the QI assessment report and a comprehensive assessment is not medically necessary, the youth shall not perform a comprehensive assessment but shall instead provide an addendum to add relevant clinical information to the most current assessment as clinically indicated. Sorry about that. So now with the QI clinical decision, when the QI makes a clinical decision, excuse me,
Good morning, everybody. I am back online. Um, Azarelli she's probably in the middle of a cough, which I can totally understand. I've been trying to battle one for a couple of weeks now. Um, I do want to just say I am reading some of the comments, and there are some comments about not being able to access the slide deck or the link. So we will go ahead and we will email that back to everybody after the webinar. It just would be very difficult to send them individually to folks that are asking for them via email. So we're just going to wait until the end and we'll email the copy of the slide deck as well as the handouts to everybody that's attending for today's webinar. So I just wanted to um, give that information. It will be up on our website in the next 3 to 5 days, but if your county has really strong tech, uh, what do you call those firewalls, you probably still can't access them. So we will go ahead and just email that after. Okay. You're welcome.
Geraldine,
Yes.
apologize. Like
Mhm.
Geraldine mentioned, I've been battling a cough the last couple of days, so my apologies.
It is all
Um,
good. We've been there.
yeah. Okay, so moving on with the course of actions for medical members and to claim medical funding, the QI assessment shall be completed in accordance with the requirements of the assessment components of the mental health service category of specialty mental health service, and this would be the course of action A. For course of action B, the medical members and to claim medical reimbursement, the QI's review, the medical record shall be completed in accordance with the requirements of the assessment components of intensive care coordination, ICC. So please note that if you would like further information on the Claiming for Family First Prevention Service Act, Qualified Individual, and Aftercare, please visit BIN 21062 for further information on that piece. Okay. So behavioral assessment when a QI referral is submitted. So under FFPSA and California guidance, a QI assessment is required anytime a youth is being considered for or placed into an SRTP CTF, including emergencies and certain transitions. For that, please visit the placement disruption examples that they are listed on the slide deck. Once the QI referral is submitted, the county MHP must ensure a full behavioral health assessment. And this will be meeting Cal MHSA standardized assessment requirements and domains. They must include IP cans as part of the QI assessment process and integrated results into the behavioral health assessment and care plan. And so a full behavioral health assessment is required for every QI individual referral because one, it's the law, federal and state rules, FFPSA and California guidance say every child considered for a group home or SRTP must have a full clinical review. Two, it proves medical necessity. The assessment shows that the child really needs the level of care and that all family-based options were considered. Three, it guides treatment. The behavioral health assessment gives a complete picture of the child's needs so the care plan is accurate and safe. Four, it secures funding. Without a full assessment, the counties can't claim Medi-Cal or federal funds. And lastly, it ensures quality and compliance. So standardized documentation helps meet audit and oversight requirements. Okay. So for this, the next couple of slides, we do want you to refer to the handout, which I would be given to you the next couple of days. And one of the handouts includes a comparison of specialty mental health services, non-specialty mental health service assessments, versus QI assessment. So we'll briefly touch through that. So the purpose for the specialty mental health services, non-specialty mental health service assessments is the purpose for those assessment is used to evaluate a youth's needs and develop recommendations for medically necessary behavioral health services. And the access criteria for those delivery systems could also be found in the psychiatric and psychological services link, as well as BIN 21073. And now for QI assessments, which those that could also be viewed in the BIN 25031 ACL 2552. The purpose is to assess the youth's behavioral health needs upon the receipt of a CFT recommendation for the youth's placement in an SRTP CTF or out-of-state residential facility. QI assessment is intended to be performed as a specialty mental health services.
Aurelia, can I just emphasize here that even though these seem like two different processes, the QI assessment includes the specialty mental health service along with a CANS assessment or a CANS needs and strengths rule completion, along with all the collateral. But just to be clear, these are not necessarily separate pieces because the QI assessment includes the specialty mental health services assessment.
Thank you, Bill, for providing that clarification. Okay, so both they do have separate minimal documentation standards. For the specialty mental health, non-specialty mental health assessment, their documentation standards are shown in BIN 23068, which include updates to documentation requirements for all specialty mental health, drug Medi-Cal DMC, and drug Medi-Cal Organized Delivery System DMC ODS. For QI assessment, the documentation, the QI assessment and QI assessment report includes recommendations for the clinically appropriate level of care for the youth and whether their needs can be met in a home-based setting. Both have different responsibilities of who performs what. First, I'll cover the QI assessment, and then last I'll do the specialty mental health, non-specialty mental health assessments. For QI assessment, who performs what? That would be a certified QI. And this can be anyone who is a licensed mental health professional, LMPH, or a registered, waivered, or trained professional that is working under the supervision of an LMPH. And just a quick note, QI assessment activities and documentation must be performed by a clinician who is competent in the QI role. Now for specialty mental health and non-specialty mental health assessments, eligible practitioners are listed under the psychiatric and psychological link services that is mentioned on the handout. And this could include primary care providers, licensed clinical social workers, licensed professional clinical counselors, licensed marriage and family therapists, licensed psychologists, psychiatric physician assistants, psychiatric nurse practitioners, and psychiatrists as consistent with the practitioner's training and licensing requirements. For eligible practitioners for specialty mental health, Medicaid and state plan, those were mentioned under the Supplement 3 to Attachment 3.1 and 1. Going back to the eligible practitioner for specialty mental health, and this would include for rehabilitative mental health services. Services are provided by certified mental health organizations or agencies, mental health professionals who are credentialed according to state requirements, or a non-licensed provider who has a signed provider agreement with the county mental health plan. For rehabilitative mental health treatment services, services are provided by or under the direction of the mental health providers functioning. And for the scope evaluation for both assessments, for specialty mental health services, non-specialty mental health assessments, They are focused on clinical criteria to determine eligibility for non-specialty mental health, specialty mental health services. For QI assessment, the scope evaluation is a broader approach that includes clinical, social, and placement-related factors for SRTP placement.
So, Aurelia, I'm gonna step in here because there's a lot of questions coming in on this, and I do want to refer back to we can send you all of the guidance and the statute that says starting in 2021 that the QI assessment includes a specialty mental health service assessment and the CANs, and that there was a um, actually an FAQ that's on the UC Davis website from October of 2021 that also addresses this, that says that it's a specialty mental health service. You should have always been completing a specialty mental health service and a CANS for each and every QI assessment. That has not changed. That has always been the process. So I'm sorry that some people are confused, but that has been the regulations. That is actually clearly stated in statute, and it's clearly stated in our guidance and in our FAQs on UC Davis website. So I'm hoping that addresses some of the concerns. Now, Anna, you're talking about something different here. We will talk about that in a bit, but all of the assessments have always been specialty mental health services and should have been billed and done as specialty mental health services, and not necessarily using one that's 12 months old. It's a point in time service. And I know Feather, you may be able to explain this a little better. If you could come off of mute and talk a little bit about this, since there's still seems to be so much confusion.
Absolutely. Yeah, so DHCF has been working together with CDSS to develop the QI, certified QI and QI assessment process. And we wanted this assessment to be reimbursable through specialty mental health services, because what is required for the QI assessment is the same information that is required for specialty mental health services assessment. So this reimbursement vehicle allows us to be funded, right, for providing these QI assessments. It is only a certified QI who may perform a QI assessment. And the QI assessment is performed in response to receiving a QI referral from the CFT. So that's the only time that a QI assessment is required, is when a QI referral is submitted through the CFT process and received by a certified QI, and that QI then conducts their assessment as a specialty mental health service, because then they can be reimbursed for the assessment through Medi-Cal, right? And so if you are going to addend an assessment, the original assessment that is being addended must have been performed as a QI assessment by a certified QI. And the only reason that you would addend an assessment is if you determine clinically that a full comprehensive assessment is not indicated because there wasn't substantive change to the youth's condition or needs. And so this is why, or perhaps there is already a QI assessment underway and perhaps a placement disruption occurred during that time, then you may addend an existing or an assessment that is occurring, right? So you will always have an assessment report, QI assessment report that is a court document, and that is based in your QI assessment. It's not the same thing. These are not one and the same. There is a QI assessment and report. right? So these are two separate documents. One is the assessment, which goes into the youth's medical record. And then there is the assessment report, which gets delivered to the court via the placing agency's caseworker. And, if the youth has already been placed in an STRTP, then a copy would go to them as well. So those are the recipients of the report from the QI. Then it gets further disseminated based on the parties, to that case. And that's all described in the privacy and confidentiality section in this updated behavioral health information notice. So
yeah, thank you,
is there
Heather.
is there any other specific question you want me to focus on?
Yeah, I think people are confusing a QI assessment with a QI with. So a QI assessment includes the specialty mental health service assessment. It
Yes.
includes completion of a QI assessment report,
Yes.
and it requires a CANS or an
So
updated
CANS is part of a youth specialty mental health services assessment. So it's not, they're not so different, right? You can receive reimbursement through specialty mental health services if the assessment is medically necessary for that youth, and that youth's assessment includes a CANS. That is part of the specialty mental health services assessment for youth. And so a CANS is a standard part of assessment. There are cases when you would want to addend, like perhaps you receive another QI referral and you're wanting not to do another comprehensive assessment because it was recently done and there aren't significant factors that would change the youth's needs or their condition or things like there's not the medical necessity for a comprehensive assessment, right? So you would do an update using, and I know that there's a claiming BHIN out there. It's 062, I think is the end of it. Is it 21062? Anyway, it can describe the ICC codes that can be claimed for doing this medical record review and an addendum to the assessment. But in that case, we describe in that first BHIN about the QI, we describe for you that it always includes a CANS. So even if you're doing an addendum to an existing assessment, you still would need to update the CANS. That is part of the QI assessment.
Yeah, so people are getting confused here. The QI assessment has three parts to it, or two, depending on how you deal with the CANS. But you have a specialty mental health assessment, and you have the completion of the assessment report, which goes to the placing agency. The specialty mental health assessment goes into the medical record, but that is completed, and then the assessment report is completed based on the assessment.
Correct.
So it may sound confusing, but it really isn't, folks.
So the process is that you would never do a QI assessment unless you receive a referral. That referral is a QI referral. It comes from the CFT. So once you receive that, then a certified QI is assigned and completes this assessment. The referral question on a QI assessment is different than a standard specialty mental health services assessment. The referral question is asking, can this youth's needs be served in a home-based setting? That is a very different question that involves a broad, look at the youth's needs. It looks at different, that's why there's so many medical records that are being requested to review, looking at social services or probation or different, circumstances that the youth may be in, their education. It's a different kind of referral question. This is why it takes a certified QI to get that referral and start to research and answer the question, the referral question. That's the QI assessment. Yes, it has the same domains that are required in the specialty mental health services assessment and including the CANs. But the referral question for a QI is different, right, than your standard QI assessment. So we need to approach it through the lens of the QI. And that's why when you're updating a QI assessment, you're doing an update, like an addendum, for example, if it doesn't need to be a comprehensive assessment. You're addending a QI assessment, a previous QI assessment, because you're kind of going from apples to apples, right? You're not trying to make a different kind of assessment, like an assessment for medical support services or medication support services. You're not trying to make that fit into the bucket for QI assessment. It doesn't work. So that's why we have to be careful that when we're doing assessments that we're sticking to the assessments that are conducted by certified QIs. And I just want to be clear, I'm part of this team that developed the policies for CalAIM. CalAIM is a much broader movement that the department is engaging. BH Connect is part of it. There's lots of components to CalAIM. CalAIM is not specifically an assessment, just so you're understanding. We did develop the access criteria to be updated under the CalAIM initiative. We developed updated documentation standards, including these assessment standards, and the BHIN being referenced here, in order to, under that CalAIM umbrella. But CalAIM is a much bigger concept paper. I mean, you can look it up. You can read all about it, but it has a lot of pieces to it. So when you say CalAIM assessment, I don't know if you're talking about specialty mental health services, DMC, ODS. If you're talking about, there's so many different documentation standards for the various assessments, right, that are all in that BHIN. The assessments, it's the BHIN that speaks to documentation requirements and how to code during the assessment timeframe. Those are what's relevant to the assessment. It's not necessarily CalAIM assessment. It's, CalAIM is big. Just so you're aware.
So one more thing, Feather, there's two actually. Could you address Charlene's question?
Charlene's question. Where's Charlene's question? Okay, so are you saying that the certified QI assessor is only allowed to submit an addendum to a recently completed clinical behavioral health assessment? That would only be the case, just that first part, if the recently completed behavioral health assessment is being performed by a QI. Because that referral question, again, it's a very different lens that you're assessing an individual. It's not a generic, it's not a basic behavioral health assessment for any kind of service. It's for QI. So it would have to, apples to apples again. So the rest of the question says, if that recent clinical BH assessment was won by a certified QI, if so, why couldn't, I can't see the whole here. The certified QI add a clinical addendum to a recently clinical behavioral health assessment that was done by a client's licensed or licensed eligible provider. It seems that we are way over assessing. So there is a provision for a youth who is placed in an STRTP. If you look at the interim regulations for STRTP, they can utilize the QI assessment instead of performing a new assessment at the STRTP. It's clinical discretion. What happens to the youth in the time that they are moving between one, circumstance to another? It's up to that clinical person to decide, is it medically necessary that we conduct an assessment? And so I'm not going to say that there's always or never a situation, right? It has to be a clinical determination. But I will say that we do allow for the SCRTP clinical team to utilize the QI assessment if they would like to, if it's been done within 60 days. because the focus of the QI assessment is the same focus, really. So that's why the clinical information makes sense in that context. So yeah, it's not just any behavioral health assessment. It would have to be a QI assessment, apples to apples again, right, by a certified QI. We're really in a unique opportunity as a QI to try to promote children and youth receiving care in the least restrictive environment. We really are trying to see if their needs can be met in a home-based setting. There's so many youth that are placed in this more restrictive and residential environment that we're trying to assess that more completely. And that's this whole movement of the QI through the ACF, the federal partner to CDSS.
So, Charlene, if you want to come off, I can answer the question that you have in there. The reason for that is because it's federal law and it's state law. QI assessment has to be completed every time a referral is done, which is every time a placement is changed. As we talked about earlier, that there needs to be a change in the child's condition. So, unfortunately, federal law says that we have to do it. State law says we have to do it. So I understand the confusion but there's nothing really we can do with that. It's law. So Charlene, go ahead.
Are you able to hear me?
Yes.
Oh, wonderful. Okay. Thank you. So I think most people on this call who've been doing QIs for years, I think we're clear, right, that the new 19-page QI assessment is its own assessment. And
that's a report. That's a report. That's a QI assessment
for the sake of this
report.
conversation, we'll call it a report. And then the specialty mental health clinical assessment, which like in our county is an additional 11+ page, very detailed clinical assessment. And then
Right.
CANS, right, that is either built into that assessment or it's a standalone, is that additional piece. I think where, at least for Contra Costa, where I know we had some confusion, and I can see on the thread other counties are with us with some of this confusion, is that the expectation that we already know we have to do the QI report every single time we get a QI referral. That's like super clear. We're super clear on that.
Right.
It's this, I think the newly emphasized wording around, and you must have a brand new clinical assessment to go along with that brand new QI report every single time. And it's interesting because the QI report, it's a 19-page report. It's very robust. It's incredibly detailed. Diagnostic information's going in there, CANS information. It's actually quite repetitive to the actual clinical assessments. And so I think what you're getting from many of us, and I can't speak for everyone, but I can speak for the folks in Contra Costa, is it feels incredibly repetitive and a degree of over-assessing. We hear you loud and clear that this is what the state and the feds have mandated. And at the same time, it's in contradiction to stop over assessing. And we have these youth who have bounced from home to home to home. And every few weeks, we are completing brand new mental health clinical assessments, CANS, and QI reports for the same kiddos. And so for me,
Charlene, I will say that the way that this has been implemented may be administratively burdensome by the county that you're in, because we don't require, like if you look at our BHIN that was just recently released on page 5, so this is the BHIN 25031 on page 5, what we're saying is it doesn't always have to be a comprehensive assessment that is completed in order to complete the QI report. If you feel that the clinical assessment that was performed by a certified QI, because the referral question, right? It has to be a clinical assessment that was done with the appropriate referral question, because we have assessments for every level of care, right? And for different needs, like if it's a medication support need, or if it's need for inpatient, or if they're having a crisis, there's different assessments that can happen based on what is the presenting concern for that youth. And so with the QI, the referral question is what is driving the assessment. And so that's the lens that people are answering the 7 domains of the assessment. So if you're going to addend an assessment that exists that you feel is comprehensive, that is using that lens, right? Then you would addend an existing assessment and complete a new report. The addended assessment doesn't have to be a full assessment. DHCS has said you could put assessment information in a progress note. You just need to make sure that the updated information, there's a reason that you're getting a second request for a referral. It's not just, there has to be a basis for the referral, the QI referral. So you would add the new referral question to the information for the reason that you are addending the assessment, and you would addend the pieces of the assessment, the areas that are relevant to that referral, and then you would complete the report. You are correct. 1 for 1, always a report for a referral, but not necessarily like a whole comprehensive specialty mental health services assessment. That has to be medically necessary. So the comprehensive one is the mental health services, specialty mental health services assessment, right? And the one that can be addended is like, if you're going to use an ICC code, because assessment or ICC, intensive care care coordination, includes an assessment component. If you're going to use an ICC code, you have to have documentation to support the use of that code. That is the addendum that you're creating to the assessment. So that completes the assessment for the medical record. But yes, you do need a 1 for 1 for the QI assessment report.
And the other thing is, Charlene, is that up until September, we did require, because we hadn't given you guidance on how to do an addendum or do it differently. So since September, when that letter came out, that's when this process that Heather is talking about became live. Up to that point, there should have been a full assessment done each time. But because of what people had said and because of the burdensome issues of that, the way the federal law and the state law were written, we worked with the feds to come up with this idea of being able to amend an assessment so that you don't have to complete a full assessment, but you still have to complete the full assessment report to send to the placing agency and to the court, and it goes to the court.
And I would say only a QI has the competency. A certified QI has the training and knowledge needed to complete the QI assessment. It is not exactly the same in that way as a specialty mental health services assessment. Not anybody can complete a QI assessment. The people who can complete the specialty mental health services assessment like that would be the broader bucket. And then of those people, only a set of people who are certified QIs have the competency to complete a QI assessment. So yes, they're using the reimbursement through specialty mental health because essentially it's the same 7 domains, but it is not the same lens. It's not the same referral question. They're not looking at the domains through the QI lens. So not every specialty mental health services assessment is a QI assessment, right? I guess that's what I'm getting to.
So I see a lot of questions. We're going to try to get through these slides, and then if we have time, we will answer them, some of them, or we'll answer them. If not, we'll be able to draft up responses and send them out to everyone. So I think pretty much, Aurelia, you were done with your slides. You just had the billing eligibility, which is pretty much the same.
Yes, that is
So,
correct, Phil.
okay, so let's move on. And then what we'll do, like I said, is once we get to the end of the slides, we can see what time we have left and then answer questions then that are in the chat. And if not, we don't get to them, we will send out written responses. So let's see here. So I'm going to go back one slide. So this is the requirement for the CANs, just as a reminder, and it's in this letter, just as a reminder that all of the CANs domains, including the IP CANs, which are the trauma and the extra caregiver requirements, are required for the QI assessment and report. If the CANs was completed within 2 months, as has been said, you can either use that CANs. If something's changed, you can update it, or you can perform a fully new CANs. If it's completed more than 2 months ago, a new CANs is required. Here's a comparison of the two. So the CANS 50 is what currently the behavioral health plans are required to do. So the QI is trained and certified in the CANS 50, which includes the standard 50 questions, the core domains, and is individually focused. There is direction coming out and guidance in the future that will clarify and align the CANs so that all the behavioral health folks will be required to also be certified and trained in the IP CANs, which on the right side of the screen is a collaborative work, and it's done with it includes the 12 trauma questions, 3 caregiver sections, additional caregiver sections, and it's integrated in the CFT. So as of this point, the QIs are only required to be certified and trained in the CANS 50. When the new letter comes out from DHCS, that will change. So at this point, you are still only required to do your certification under CANS 50 for your annual training or annual completion. Okay. So
I think too, Bill, with a caveat to that is that the QI is expected if they're using the CANS 50 to obtain the IP components from the CFT in their collaboration, not collaboration, but in working with them and consulting with them and interviewing, they would obtain those components because it is the expectation that the IP CANS components are completed as part of the QI assessment report.
Correct. Thank you, Feather, for that. Okay, so now we're going to go into the privacy and confidentiality section for the assessment activities and QI assessment report from the letter. So this seems like a lot of information and it seems pretty technical, but it's pretty easy once you break it down. The QI assessment is part, or the QI assessment report is part of the juvenile case record. So once you complete that, you are required to give it, the QIs are required to give it to the placing agency. and then we'll go through how that process works. It's all protected under state and federal law. Confidentiality cannot be released except to persons expressly allowed access. And then there's all kinds of WIC codes and federal codes there to look at. So part of this process with the QI and being able to access reports and being able to talk to people, QI is a member of the multidisciplinary team based on WIC section 4096G8. Consistent with WIC 827, 10.850.1, and Civil Code 56.10, members of the multidisciplinary team are able to inspect files. So they're able to have that information to look at. So that's why you're able to look at, as a QI, able to look at information that is provided to you by the placing agency. So the other part of that is for the QI to complete all of their activities and get everything completed. They need to be able to talk to and engage all of those that are part of this CFT, the team, supports for the child, people providing other supports and other services. So that's where a release of information comes into place. So the county placing agency is required to obtain a release of information for the QI to be able to access medical information, talk to all of those that are involved in the case. If they're not able to get that ROI signed, the county placing agency should go to the court and get a court order. Now, I do know that there are some counties that have already put that as standard language in their court orders, that the QI is able to access and complete and talk with those that are needed for the assessment. Just a couple quick things here. HIPAA allows disclosure without consent when required by law. WIC 4096G mandates that the QI share the assessment report with the placing agency. Now that, and the law also says the STRTP where the youth is or will be placed. What we expect is that will probably be the placing agency that will do it with the STRTP, but the QI, based on these laws, are able to share the assessment report, not the assessment, with the placing agency. Next slide. So once the county placing agency gets the assessment report from the QI, then they must attach that report to their STRTP court review hearing report that needs to be to the court, that needs to have the court review the STRTP placement within 45 days, but no later than 60 days of the placement. And these are the information, the different WIC codes as far as what the needs to be in that report, and for probation and child welfare. That report will be required and served to all of those that are party to that case. And so everyone will get a copy of the report that will be submitted to the court. This is just something else in WIC section 827. Assessment report may not be disseminated further to any person or agency other than a person or agency authorized to receive the documents without approval. So the assessment report can go to the court and it will get distributed to or served to all of those that are party to the court. If it needs to go to somebody else, the court then has to order it. Somebody another person cannot give that out based on law. Okay, once the report goes to the court or the hearing, the court must consider the report and other evidence presented. They make determinations and findings based on certain federal and state laws, and they must approve or disapprove of the placement within the 45 days or 60 days, and then provide basis for their determination. So the youth does retain privacy and confidentiality rights, including seek legal advice regarding the QI assessment. The court may impose limits on the sharing of the report. So if it went to the court and somebody said, well, we don't want that shared with the parent, if there's good enough reason, then they could deny or limit that sharing of that report to whoever that they are talking about. The big thing here is county agencies, child welfare, probation, behavioral health. You should consult with your legal counsel for compliance with federal and state law. So whatever, we're not attorneys, we're just giving you certain sites. You should always check with your county counsel on this privacy and confidentiality information. Okay, so now we're going to go, there's a few quick updates we're going to talk about on the QI referral and the assessment report template. The referral template has been updated. Most of it's the same. Some of it has been moved around and changed formats. The biggest thing that we put in here is this red section. So placing agencies, probation, child welfare are not to submit a referral form without a consent to treat form in collaboration with mental health plan, and a signed ROI with a release for the QI to be able to talk to the child and family team. So those are the first ones that does have to be part of the referral. If they are not, then what happens is the QI is not able to start their process, and they still have the timelines, but because all of that information is not provided to them, they're not able to start doing the assessment, and therefore it may run over the 30 days and the county may not receive federal funding for that placement if it's not completed within 30 days. So it's really important for those of you that are on here from placing agencies, child welfare and probation, that this is done at the referral and the referral is completed in the timeline that needs to be done. Again, if you need to get a court order, you need to include that or figure out with your county. Maybe it's something, like I said, some counties have incorporated that into their court orders so that it's already there, that they can get information, the QIs can get information. The other thing we did on the referral was on pages 10 and 11 of the referral, we included instructions for completion of the referral. So it gives you everything and lays out everything exactly what needs to be included in that referral for the QI to be able to start their assessment. So as far as the assessment report, it's also had some updates. Again, most of them are either language changes to comply better with the federal and state laws and the requirements of the assessment and what needs to be documented, or moved around, or just additional information that we felt was important to clarify those sections. So one of them here is the recommendations and interventions. So this section actually goes through and there's a whole bunch of interventions that are included. It gives check boxes as far as to be put in there that they're either recommended, currently being implemented, or interventions that are currently being provided and not in place, or any services that might be there to address the child's short and long-term mental health and behavioral health goals and treatments. So that section is really important for the QI to complete, because those are going to be part of your recommendations that go to court. And for the court to be able to order any specifics, that is important for them to have. The other section here that we have is just section G, which talks about can the assessed needs be met in a family-based setting or Indian home? And it's a yes or no. And then there's a narrative box that describes the barriers and reason why the needs of the youth cannot be met in a family setting. So that, again, is really important, because that will help the placing agency, and it will also help the court to look at what is needed to get that child back into a family-based setting from an ST or TP, if that's what you're recommending. This is the alternative settings. Again, if you're not recommending a family-based setting, you feel like the needs can't be met in there, then this is where you would select what might be needed. You've got ST or TP, you got CTFs, you got the different pieces there, and then you've got a narrative box. Again, why is that setting the most appropriate for that to meet that child's needs? And again, it's really important. It may be a specialized program. It may be, a substance use program. It may be sexual offenders, whatever is needed, and why this is the most appropriate setting is what you would put in this box. So tribal QIs. So we are still working on how the tribes are going to be designating their QIs based on law, state law. They're in WIC section 16501. The tribes are able to designate their own QIs if they want. And so we will have that information, working on that with the HCS, and we'll have that information out sometime in the future here that will give the tribes the direction on how they do that. Now, I do know that there is at least one tribe currently that did designate, and we've talked to them, and they have followed all of the designation and done all of the things they need to. So they are having their designated QI within their tribe do all of the QIs assessments for their Indian children in that area. Okay, certification process. Again, this is just kind of an oversight. This is actually, most of this is the same thing that's in the original ACL and BHIN 21113 and 21060. So these are the people that have responsibilities within that. You have CDSS, DHCS, UC Davis, and then the behavioral health plans. And we'll just kind of go through this real quick. Again, behavioral health plans need to verify license. They need to make sure that the QIs are registered and take the initial training before they complete any assessments. They need to make sure that each year there's annual trainings completed. Verify that they've completed the initial ongoing trainings, certified in CANS initially and annually, and verify if they are doing activities for or QI assessments for Indian children, that they have specialized training. This is something that we're still working on. So based on the QI fundamental training that we currently have, there's a 3-hour piece that's a ICWA piece, that if you've taken that, then it fills this requirement here at this point. We are looking at doing something further so that there will be more trainings that will be offered and required for those that are not designated by the tribes, but they're doing QI assessments for Indian children. So here's the training requirements. So you have the prerequisite, which is on the UC Davis website, which is a video that you need to watch that talks about the California Child and Family or Child and Youth System of Care. Then there's the 18-hour or 16-hour, 16-hour? No, 18-hour, sorry. QI fundamentals training that is at this point we're usually doing 6 half days, but some of them may be 3 full days. So if one of the things, if you are a new QI or you have new QIs come into your county, if the fundamentals course is not available right away, they need to take the Getting Started training webinar that's still on UC Davis. They'll also need to do the prerequisite webinar, and then they need to sign up for the next available QI fundamentals training. So they shouldn't be starting any QI assessments until they at least complete the Getting Started in the prerequisite. And again, that's on the UC Davis website. Annual trainings, this is new. Annual trainings are 8 hours per year, a minimum of 8 hours per year. They may change and we may mandate specific courses, but at this point we've got on the UC Davis website, we've got trainings that can be taken. You can also use your courses that you're using for your BBS license renewal, as long as you keep documentations that if we need to see those, that you can provide those to us. And here's how the annual trainings work. So we started the QI fundamentals training in January of 2025. Everybody that has completed all the modules for the training in 2025 needs to begin their annual training in 2026. If you didn't complete all the modules in 2025 and you need to make them up in 2026, then your annual training doesn't start until 2027. So then in the future, if you start your training, you get the QI assessment, the fundamentals training in 2026, your annual 8-hour minimum training will start in 2027. And again, this is all laid out in the letter, and I think somebody put in the email addresses for the FFPSA, DHCS, and CDSS inboxes so that you can always send information to there or ask questions there. Ongoing QI monitoring. So at this point, at any point, if the QI does not meet the minimum qualifications, the behavioral health plan should suspend the QI from performing assessments. So if for some reason their license is suspended or whatever, they haven't completed the annual CANS training or certification. If they didn't complete their annual yearly minimum 8-hour training, then that person should not be completing any assessments and should be suspended. There should be written notice to the 2 email boxes here on the screen. And then once those are done and that QI is able to start doing those trainings or assessments again, then you would email back to these email boxes letting us know that that person is again qualified to complete the assessments. Okay. So here's again the emails. So DHCS or DHCS FFPSA inbox and the CDSS inbox. Here's some websites. We've got the CDSS Families First website and the UC Davis website. And now we're ready for questions and answers. We do have some time, so I'm gonna ask Geraldine to start asking questions that are in the chat that we have not gotten to, um, and then we can start answering those questions.
Sounds good. Thanks, Bill. James, you can go ahead and stop slide share. I am just going to scroll up real quick. I think if we have a lot more questions on the first part during Aureli's presentation, we can get back to that. I'm just scrolling up, Bill, for a couple questions on the ROI. Oh, and I lost them. Okay, so there were some questions about obtaining the ROIs and sometimes having the court requesting them from the court is adding to the time, right, of getting that done. And ideally, the placing agency should be sending you the QI referral with those completed ROIs, but I know sometimes that's not always happening. So one of the question is, what if the referral only includes consent signed by the social worker, not the member?
That's a good question, because I think the consent has to be signed by the member, which then doesn't give the QI the ability to even start doing anything on the assessment. I don't know, as Aureli, do you know that, or Feather, are you still on?
Well, yeah, what was the question? I'm sorry.
What if the referral only includes consent signed by the social worker, not the member?
So it has to be a legally completed document. So we need to make sure that if the youth is required to sign, that they have signed. If they haven't, then the QI is limited to inspecting the case file as part of that interdisciplinary team, multidisciplinary team. So there are circumstances that can limit a QI's access to appropriate records needed to complete their assessment. And if those circumstances are impacting your ability to complete the assessment report, then they should be documented in that report. The judge basically needs to know any barriers you may have to reaching a determination that is conclusive.
Yeah, and if for some reason the court has authorized a social worker to be that person, they need to send you the court order or something that shows
Right.
that they have legal authority to do that.
Okay.
I have this question.
Go ahead.
Do you mind if I answer this question in the chat? There's a question, Erica Jennings. It says, I thought I heard you say that there are circumstances where a QI assessor might decide that a review of the medical record is sufficient, with the understanding that a gathering of all the information required to complete the report through a QI lens. Is that true? And can you restate what those circumstances may be? So we would want a medical record review alone is not an assessment, right? So if there was a recently completed QI assessment and the clinician determines that the youth circumstances impact all of, those things haven't significantly changed, that you would want to retain that information in the that recent QI assessment, then you can addend, why are you receiving another referral? What are, the circumstances, what's going on, and what do you need to look at? And perhaps your discussion with the CFT and updating the CANs to identify, is there a need for a more full assessment? If that's all you need to do is talk to the CFT and update the CANs, and then just that review of the medical record, you can addend an existing QI assessment, but you can't addend any assessment because the referral question for the assessment has to be relevant to the QI's, what they're assessing. So assessments are not, I mean, they're not so general, right? Like really when a person is conducting an assessment, it's based in medical necessity, which means there has to be a referral question and it makes sense clinically to assess the need. So we have to justify our assessments and we have to decide what's the appropriate action to take. And we can't just addend any assessment. You can't take an assessment that was completed by, say, a psychiatrist for medication support to be used as the QI assessment that you're updating. That doesn't make sense. Even if it was done by, maybe you have a licensed social worker who was assessing that individual for a particular evidence-based practice. It doesn't make sense to use that for the QI, right? Because it's a different referral question. It's a different lens. So we need to make sure that we can get a lot of information for our assessment from a medical record review. There's nothing to say you can't use a medical record review as part of your assessment process in acquiring historical information. But we do need to get the relevant current information with that referral question in mind in order to complete either an addendum to a previous QI assessment or to complete a full QI assessment. So that's just to clarify in what circumstances we might use an addendum.
Thank you, Heather.
All right. I just had to turn off my camera. Apologies.
Lost her. I'm going to try to scroll back in the chat. There's a lot here. Find out where she was.
There's Carla's question about the ROI that asks, she had a QI where the youth did not sign the ROI and the holders of parental rights are out of the country. So the social worker signed the ROI forms. This goes back to, Bill's comment about needing to validate the authority of the social worker by the court. So we need to make sure before we would, have access to any records that the ROI was providing access to.
Yeah, correct. Now, I did see some questions way back in the up further that talked about smart care. Heather, can you address that? Is smart care a statewide system or is that a county-based?
So it is. So smart care is a commercial product for electronic health records.
Mm-hmm.
And DHCS, it does have a stakeholder as CalMesa is in supporting smart care and updating it to reflect DHCS's policies. This is a policy update that can be elevated, but I don't believe that DHCS has any direct way to update a commercial product. It would have to go through that, through your county to elevate it to your, or let CalMesa know, like we have an update to this policy and a template that has been updated. And can we, update the EHR? But DHCS does not directly update the commercial products of the counties for EHR.
Thank you. Geraldine, you back on?
I am back on. Apologies. I stayed on my phone, so I wasn't completely gone.
Okay,
Oh,
no worries. So I couldn't find out where you were as far as question-wise, so I'll just turn it back to you.
Okay. I think the question I had was if the CANS was completed within 2 months, but not by a QI trained individual, is the QI required to complete a new CANS?
So the CANS has its own certification. And we don't add requirements to completing like an assessment that has its own training or a CANS. If you have completed that certification for CANS, so you know how to do the CANS to standard, the QI can then utilize that information as part of the medical record review. And then they can update the CANs, with consultation with the CFT or independently, just to make sure that they have the most current representation of that youth's, condition.
Thank you,
That's
Feather.
why, sometimes in assessment, we have assessment technicians perform assessments. Or, like there are trained people who can do those instruments, and the instrument only requires a certain standard that has to be met to do the instrument itself. The interpretation of that in the context of the QI question is what the clinician is doing.
And I lost some of the chat. So forgive me if I don't get to your question, but we do have it tracked. So if we miss anything for today, we will go back and compile some answers for you. There's a question of, I'm not sure if it's been answered. When should we expect phase 2 of the CANS alignment for IP CANS to replace CANS 50? Is the 2-day mandatory IP CANS required for non-QI staff completing the IP CANS for BHPs?
So that is still in the works. I've heard that DHCS is working on it and trying to get it out before the end of June. However, I do not know where it's at. If a behavioral health plan person, if a clinician is not a QI, then they are not at this point required. Well, a QI is not required to take the IP CANs, and neither is anybody in behavioral health, unless they are doing CANs. They're contracted with the placing agency to do CANs for them. So there is a circumstance, and that's laid out in a recent ACL, that if the placing agency, so a lot of probation agencies don't do the CANs, so they're contracting with their behavioral health folks. If those folks are doing CANs, IP CANs for the placing agency, then they are required to have all of the IP CANs training and certification. But at this point, if you're not doing it for that specific reason, you don't until that letter comes out. I hope that answers the question.
Just going back to the questions on ROIs, if the member did not sign the consent, it was stated the QI would be limited to a case review. So we would still move forward with completing the report even without the member's signature?
Yes, you would still complete it. You would not be able probably to make many recommendations, and you would state that in the report itself, so that the court knows that you did the best you can. You would show them what you use and do the best that you can as far as recommendations. But if you're not able to make a determination if the needs can be met in a family-based setting or not, then you just state that in the report, and then state that you didn't have enough information to make full recommendations because you didn't have access to the CFT or other medical records. You only had access to the juvenile court records.
Okay. Jill, I see your hand raised. Come on in.
Yeah, that was had a question about that. So if we do not get consent by the you're talking about the adolescent, the client, or then we are only able to do the QI based on the information we receive from either the probation officer or the social worker, because they are representing the court and the court has custody, legal guardianship or custody of the client at that point. Is that correct?
Well, based on law, because the QI is a member of the multidisciplinary team in statute, then you do have access to review those records, the juvenile court records from probation and child welfare.
Okay, but not because I work for behavioral health. I mean, we're contracted providers for behavioral health, so I could not review our records without the consent of that minor.
Correct.
Okay, that's what I wanted to know. Yeah,
Yeah.
thank you.
Sure.
And Bill, there's some comments about some formatting challenges with the QI assessment report. So somebody said that the PDF locks once the QI assessor signs the document, and then the narratives on page 2 becomes hidden. So is this something that's going to be revised and redistributed?
Yes, we are actually in the process of fixing problems that we know of. We've had quite a few folks let us know. If you have not emailed us, email the 2 inboxes and let us know what issues you are having so that we can make sure that we get those corrected for the next version that is put out there.
Okay.
We do thank you, everyone that has notified us, and we are working on getting those corrected.
Next question is, what if a placing agency continues to send QI referrals without having child and family team meetings?
That's something you should talk to your interagency leadership team, your leadership management team, and then they should bring to the full county leadership team to make sure that everybody understands the policy and knows what needs to happen. That's something that should be done, internally.
Because Bill, the CFT is the source for the QI referral, right?
Correct.
So the QI can ensure that the source for the referral is a true source.
Should, yes.
So that's important.
Yes. Yeah. So again, take it to your, if you are in behavioral health or child welfare or whoever, take it to your management team, let them know the issue, and then let them know that, they can go to the interagency leadership team, the ILTs within the counties, because there's an MOU that talks about how they can all work together and how they're supposed to work together. And then that can be brought up and discussed and figured out how that policy, why it's not happening, what needs to happen to make it happen, all of that.
Okay. Okay. And thank you for that information.
Oh,
Sorry.
sorry.
Go ahead, Heather.
No, I was just going to say there was a question about the SUD information in the ROI. And yes, the law hasn't changed regarding SUD information. We still need to have that explicitly released. There is sometimes SUD information when you inspect the case file, so you may be able to obtain it. Remember that the assessment is part of the medical record, and what goes into the assessment report is not the entire assessment, right? So just be aware of what the limits are to your confidentiality and what's private for the youth, and just remember when you're filling out that assessment report, they are not the one and the same. The assessment report will not have all of the assessment information in it.
Okay. Yeah, and just some comments again that a lot of the referrals are coming in without signed consent forms or ROIs before the child and family team meeting has occurred. So that sounds like it's an ongoing challenge for our QIs that they're dealing with.
Yeah, and again, one of the things I would recommend is take that to your management team and have them take it to the interagency placement committee or the interagency leadership team to discuss. We are also working on updating the case worker training and providing a new training for the caseworkers for child welfare and probation on how to actually complete the form, um, the referral form, and what their requirements are for that. So hopefully we'll be able to get that out here, and get that up and running. We're going to do I think we're going to do a training, record it, and then have that available for them to take.
And this might be another ILT discussion as well, Bill. There's another question that placing agencies have expressed not feeling comfortable using our consent forms. Can they create their own consent forms? How should we address that? Letting them know this is part of the policy, or should we have specific consent forms created for this process?
At this point, you should bring that to your ILT, because they would be able to figure out and decide what form is going to be used, because the placing agencies have their own forms. Behavioral health has their forms. We have done one small pilot, to try to develop a universal ROI for this purpose, for the QI. However, that's a long ways off, because we've just done the pilot, and now we need to take it back and look at all of it again, and get all the legal folks involved. And so, but we are looking at trying to figure out a way of helping that out in the future.
And I'm going to just add in the chat. We shared this earlier. And again, if you can't access, we will put this in our website, and we'll also email it out today. A few questions were submitted ahead of time that we were able to craft answers to. So you're welcome to refer to that document, and we'll probably add that on based on some additional questions that we got for today's webinar. But I want to just bring it up just to an open floor if anybody needs additional clarification or has a lot of questions, going back to our discussion about the SMHS assessment versus QI assessment versus CalAIM, and the report versus assessment and things like that. So feel free to just raise your hand and unmute yourself. But we have about another 15 minutes to get through some of those questions.
This is Carrie. I'm not able to raise my hand, but can I ask a quick question?
Of course, Carrie, come on in.
Thanks. Actually, this question was written by someone else, and I think it's important, and I know we've struggled with this question. It's around how long a QI assessment report is valid, if you will. So we have a lot of cases where kids get assessed or not a lot of cases, but some cases where kids are assessed as meeting STRTP level of care. But then the placing agency goes in a different direction. And then 6 to 12 months later, they might want to place in an STRTP. And so there, we get questions around, can we use that old QI assessment report? And, so forth. So sorry, that was kind of verbose, but the question really is, how long does a QI assessment report, is it considered valid?
So Carrie, in that circumstance, there will be a new referral. So every referral, like a report is the second part, right? Or for every referral, there's a QI assessment report. If you're talking about, is the information in the report changed? That would depend on factors with the youth. So what in the youth circumstances have changed? Has their condition changed? Are there other assessment factors that you're looking at that need to be included in the report? So I wouldn't use the same report ever. I would base it on the most current assessment of the youth.
Yeah, and I agree. I think the big thing is, and Feather has pointed this out for years, that this is a point in time. And so if you're looking at a couple months even, there more than likely has had something change. If that child's been in custody, if they've been in a placement, there may be a lot of things change. So the placing agency, if they do find a place for that youth, then they should do a new referral and a new assessment and report should be completed.
And there will be more clarification around the QI specialty mental health assessment versus the QI assessment, because I think there is still some question around that.
I think that the importance is the QI assessment. It's like not every specialty mental health services assessment is a QI assessment, but every QI assessment involves the domains and the CANs of the specialty mental health services assessment. So that the specialty mental health services is a vehicle for reimbursement if all state and federal requirements are met for Medi-Cal. And that's why we wanted, because they basically are the same in the sense that the domains are the same, you should be able to have no issue with getting reimbursement if they're a Medi-Cal youth and the provider is a Medi-Cal provider and all conditions being met. That's why we said every assessment should be a specialty mental health services assessment, because those are the same documentation standards that are required for the QI.
Right. So if I got a specialty mental health assessment from an STRTP that was done 3 months ago and it has all the domains that a QI assessor would do, then why would I turn around and have to reassess the youth for the QI assessment report when part of the whole push is to not overassess kids? So that's where some of the confusion is. Why would I come in and do the exact assessment? Because to me, this is the first time I'm hearing that when you do an assessment, there's a specific assessment question you're answering. I mean, sometimes I do an assessment on a kid and the question is, you're kind of heading towards a diagnosis, but
okay, so it's a diagnostic evaluation, right? So that's typically the code that we use, because in the course of conducting a full assessment, you do have diagnostic criteria. Some people opt not to include a diagnosis in their assessment. Of course, for Medi-Cal, we do, but yes, often we're using the CPT code for psychiatric diagnostic evaluation, which is needs to be right. That's the focus of the assessment. QI assessment, that is not the focus of the assessment. But yes, you could identify conditions, disorders, circumstances, social determinants of health, things that need to be part of the care plan for that youth and that become part of that report.
Yeah, I think Carrie, as Feather said earlier, that the QI assessment, the specialty mental health piece of that assessment, is specifically looking at the needs and strengths and if those needs and strengths can be met in a family-based setting. So you're making all of those determinations based on that assessment. That's totally different from my understanding. I'm not a clinician, but from my understanding on a normal specialty mental health done by a clinician. They're not, they're looking at all those domains, but they're not specifically answering that question.
I think that's what it is. It's the question that that's being asked. Like, as a clinician myself, I have different requests for assessment, and I am specifically looking at the referral question, so I can identify which assessments need to be utilized and what type of records I'm going to require for review, and then looking at what sources of information for clinical interview do I need to involve, especially for a youth, right? So the referral question for a QI is different. And STRTP, if they have just recently conducted an assessment and that youth has stepped out of an STRTP, either they've gone into a psychiatric, they've had an inpatient stay, or they're stepping down into the community, something about their condition, their needs, or their circumstances have changed, right? So we would capture that when we receive the next QI referral and we're conducting assessment. What happened? Why do we need to increase the level of service, or why do we need to step down the level of service? Maybe the youth's needs can be met in a home-based setting now. So the referral back to an STRGP is inappropriate and based on these reasons, right? And how their needs can be met in a home-based environment with wraparound services or whatever it is that the QI is determining how to meet their needs within the community. And so that the circumstances of leaving the SCRTP, we can't just use the SCRTP assessment because the focus was completely different when they conducted that assessment. And I know we talk about over-assessing youth, and sometimes that's because clinicians want to start with the clinical interview and go question by question instead of starting with a medical record review and then, gleaning from that historical information, maybe revisiting it, validating some of it, but then not necessarily putting the youth through a full clinical interview if it's not necessary, right? We shouldn't be able to make those clinical decisions about how to capture the information that we require to address the assessing question. I hope that helps.
Sorry to take up so much time. Thank you.
No, not a problem. It's
No worries,
this is a
Fred.
very helpful conversation because I think there's a lot of subtle, we have a lot of process. There's a lot of administrative process in the places that we work and the different policies that we're following. And, and sometimes we kind of get lost in the, like, gosh, there's just so many pieces. How do we make this simple for the youth in terms of what their care requirements are? And so we're really trying to find a way to meet the youth where they're at, not to overassess them, just to really ask the right questions, right? To get the information that we need to kind of help them along. But I think we get caught up in these administrative processes. We kind of start over at each turn.
Thank you, Feather. Liliana, come on in.
Thank you so much. I'm Liliana from Merced County. I just had a follow-up question related to how long an assessment is valid for. We see this more often with our probation placements because sometimes youth are placed in juvenile custody, and in some cases they are having a CFT meeting, sending us the referral for the completion of the QI assessment report. But they're hesitant to want to find placement because there have been occasions where we've recommended family-based setting opposed to STRTP. And so more recently, we had where a youth had been placed, I guess it had been more than 30 days since the QI assessment report had been completed. And we were asked to redo the assessment. If not, they wouldn't get the funding. And so that's where my question was kind of posing from. And so I know you guys answered it briefly, but I'm not sure if there is an actual time frame, especially in those kinds of situations.
So we do need to make sure that the assessment, if it's going to be reimbursed by Medi-Cal as a specialty mental health services assessment, even if we're addending an assessment and we're getting reimbursed through ICC or, we need to make sure it's medically necessary. So if we can determine that there have been absolutely no impacts to the youth that would change their behavioral health needs, even a delay for 30 days in juvenile hall, I mean, what is happening with that youth? It's hard for me to believe that everything has been static, right? I can find out if I need to do an assessment by briefly looking at the record and maybe interviewing the CFT about the referral to see why is another referral being made. It's very rare that you'll have a purely administrative referral. But if you think that that's what's happening, then it's not appropriate to seek reimbursement through specialty. And then that needs to be addressed with the referral source.
We have another Liliana that has her hand up.
Yes, thank you. I do have a question. Feather, you've mentioned each referral we are answering a question. In our county, our foster youth, very seldom are we getting a pre-placement referral. We are getting emergency. So their reason for referral is they're in a new STRTP.
Okay.
And I have to really work to get what is right now, or why were they placed, what is the current immediate behavioral health safety need. I often cannot even get that answer. So I know the referral form has changed. So when you're saying answer the specific question for that referral, is it what is your question, just to clarify, why they are now at that STRTP? And if that, no, okay. So thank you.
Well,
No,
no, it can be,
it
right?
can
No,
be,
like
right.
if the
But the
reason for
main,
placement in the STRTP should be outlined in the referral. There should be a justification for why the placement was an emergency placement. And so you're not second guessing other clinical people, but you are saying the ACF, which is the CDSS's federal partner, they have tasked the QI with saying, can this youth needs be met in the community? Sure, they may be able to be met in the STRTP, but is that the least restrictive environment? So the QI is really a kind of a novel idea coming from the feds about we need to make sure that we're not overly restricting youth and just putting them into beds. We need to make sure that truly their needs cannot be met in a home-based setting. So yeah, so
and I
you're
think
right.
that's the question, the main question that QIs need to answer on any referral. What the needs and strengths are, and if those needs and strengths can be met in a family-based setting.
Okay, so we are doing that already. I was just,
Yeah.
when they were saying like every time the question, I'm like, well, are they putting that in the referral? But
Yeah.
yes, we're always answering that at that specific time based on the information provided. Because like I said, we often cannot even get why that emergency placement occurred answered.
Yeah.
Thank you.
And I will say too, the IPC, they're expected to review the QI's assessment in reaching their determination, because the IPC is really supposed to match the youth's needs with the best placement. And so they are required to inspect, like to review the QI assessment as part of their determination. So they should be having like a question that they're answering as well in terms of why was that STRTP selected for that emergency placement? It could be that they have a specific program there. So when the QI is conducting an assessment based on an emergency placement referral, they really should be looking at why the placement occurred. Like, what is it about the STRTP that was, meeting that youth's needs, and see if that can be replicated in a home-based setting, because we're not second guessing other people who are doing clinical impressions, but we are trying to get we're trying to step back and really see how does this youth operate in their environment, and can we do this in a less restrictive way?
Yeah. So I think one last question here from Misty. Misty?
Yes, thank you. This kind of ties into the same topic that we're already having. I'm guessing I'm just needing a little bit more clarification. So this is an example. There's a QI referral that I've completed for a kid historically. Kid was 14-day notice, unfortunately, and there was no QI referral submitted after the fact. Kiddo was placed in an FFA home. This was a couple months ago. Now we're running into an issue, or I've just received an email about it, that they're wanting to request a QI assessment to reassess kiddo to see if they're appropriate for this placement or if higher level care is needed. So I'm curious regarding like their referral. Now, some of the questions that I've already asked them was, were there any behaviors or concerns that are leading to the question of if the placement is appropriate, in order to see if the QI referral is necessary? I'm just wanting some feedback on that.
Yeah, I think they should do a new referral, and provide all of the updated information on that's happening in the new placement. all the behavioral health issues, all of the everything that's going on in the new thing. So there should be a new referral made for you to be able to start that assessment.
Okay, that's what I was thinking. I just wanted clarification. Thank you.
Yeah.
Okay. Thank you, Misty. Well, I want to be respectful of everybody's time. It is 12:01, so I want to thank you all again for being here today. We do appreciate your time and collaboration and the partnership in trying to clarify this guidance, and we look forward to continuing to do that with you all. If you miss a portion of this webinar, again, we will have the recording, the handouts, hopefully the Q&A for you all to access in our UC Davis website in the next few days or so. So please make sure to check back. Please have a good rest of your day. I hope you all have a great first week of 2026. Please reach out if you have any other questions, and we will see you next time.
Yeah,
Thank you,
and
everybody.
we will take all the questions that we weren't able to answer and draft responses and send them out to everybody that's part of
Yes,
the webinar.
you will have that. We'll stay on for a little bit longer, but I hope you all have a great day.
Yeah, and just for you guys to flag the question in the chat by Amanda Rosen regarding the CCRP and a step down to an SCRTP. They're both in the SCRTP category, so we need to look at that to say, is another referral required? So we could look at that, take that back.
Yeah, and that's discussions that we need to have with those folks. I've been having some discussions with them, but yeah, because it is such a short, I mean, it's supposedly 10-day or less.
Well, not even that. I'm just thinking it's in the same level of care in terms of
Right.
like STRTP. And so like PRTFs are going to be inpatient, but then CCRPs are STRTP, which is the QRTP. So
Right.
moving between one and another would be like an address change, or so we would treat it that way, I would think. But the needs will change, right? So I would think we would treat it like that. They could do like an addendum and report. But anyway, we could take it back because it still is STRTP level of care. We may not even need just putting it out there. It's a good question.
Yeah.
Right. Thanks, everybody.